Hey everyone, welcome back to the Dietitians and Nutrition Support Podcast. Today we're continuing our discussion on diagnosing malnutrition in complex disease states. Timely and accurate malnutrition diagnosis is important because we know that malnutrition is strongly associated with increased patient morbidity, mortality, and prolonged hospital length of stay, as well as higher healthcare costs, regardless of the underlying medical conditions. Early recognition enables targeted nutritional interventions that have been shown to significantly improve clinical outcomes. Joining me today is registered dietitian nutritionist Lena Beal. Lena is nationally recognized as a critical care dietitian and is also a certified clinical transplant dietitian and media spokesperson for the Academy of Nutrition and Dietetics, with over 25 years of experience at the forefront of high acuity medical nutrition therapy. Across her career, Lena has specialized in advanced heart failure, trauma, burns, complex surgical recovery, and organ transplantation, where she's provided precision nutrition support through enteral and parenteral therapy for patients whose lives depend on metabolic stability. Her work has spanned multidisciplinary critical care teams, where nutrition is not an afterthought, but an integral component of medical intervention. Lena currently practices at Piedmont Atlanta Hospital as a cardiovascular dietitian, where she continues her leadership in heart failure and transplant nutrition. She is among a rare group of dietitians with combined expertise in trauma, burns, and heart transplant, bringing to our podcast a depth of expertise that uniquely positions her to speak on the complexity of nutrition support. Beyond the bedside, Lena is a published researcher, international presenter, including the International Society for Heart and Lung Transplantation, and a trusted national media expert featured in Health, Very Well Health, Business Insider, and Parade. Her voice bridges science, clinical precision, and cultural relevance. A proud HBCU graduate of Southern University and A&M College, Lena is passionate about mentoring future dietitians and elevating representation in critical care specialties. She believes deeply that nutrition support is not supportive care, it's life-saving medicine.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
Lena, thank you so much for joining us today on the DNS Podcast.
Thank you for having me, Christina.
So you've worked with some of the sickest of the sick hospitalized patients. So when you're evaluating a complex patient, what are the most important clinical signals that raise a concern about malnutrition?
So first, I just like to level set that I am I guess you could say, privileged to work with the population that I do. It's very exciting. It's up and coming. Advanced heart failure, LVAD, and transplant patients do provide a challenge to us clinicians. But to answer your question, malnutrition in advanced heart failure patients really hides behind fluid. And so we look for fluid overload first and foremost, which can mask severe malnutrition in that evaluation. So patients may appear weight stable while actively losing muscle mass and functional reserves underneath that fluid weight gain. So we look to try and pinpoint whether or not that person has had drastic weight loss within the prior 3 to 6 months of coming in and presenting to our clinic, and then any other changes like insufficient intake, diminished functional status, and that could be a series of things where, they're not feeling well enough to stand up and cook. They don't have the strength or the wherewithal to go even shopping to the supermarket. We see a lot of instances too where the insufficient intake is a byproduct of them feeling full fast, which we call early satiety. They can take a couple of bites and now they're too full to finish the rest of their plate. So that actually presents too as some abdominal bloating or discomfort that they may describe in that initial interview. So we look for all of those things, again, as byproducts of that fluid accumulation or overload masking what could easily be moderate or severe malnutrition.
Well, across all care settings, sometimes we're challenged with accurate intake data. It may be unreliable. It may just be incomplete, whether it's a patient in the ICU and the nurse hasn't documented intake, or if it's somebody like you were saying, in the home setting where maybe they're not accurately telling you what they're eating. So how do you assess their nutrition adequacy when the numbers really aren't telling you the full story?
So you're right. The reliability of weight alone was, as I just described, is one of the things that we certainly cannot do. Um, so if they have, changes in again weight or BMI, we're not able to use that. But two of the things that we use in the inpatient setting is the malnutrition screening tool that the nurses do for all patients within 24 hours of admission. And so two of those indicators have to do with, again, unintentional weight loss, which they may describe, and to what degree we use the criteria that we have as far as scoring malnutrition. To what degree? What do I mean? If it's under 3 to 5%, if it's greater than 5%, greater than 10%, so on, we can use the degree to determine where we are. The second thing is inadequate PO intake and what it's due to. So they will generally describe what that is. So then when we go behind that and do the interview with the patient, we'll dig deeper and we'll say, have you had any changes? So for instance, in your appetite over the last, 2 to 3 months. And what they'll describe is something like, yeah, over the last week or two, I haven't been feeling well and I've not been eating as normal. I may eat once a day just because I know I have to, but I don't necessarily feel like it. Or they'll say, I'm too tired to eat, and all of those things. So we can dig a little deeper in the interview because this fluid can hide starvation, and again, in an advanced heart failure patient. And so this, our malnutrition diagnosis has to go beyond body weight.
When you're creating your nutrition care plan, how do you incorporate other factors like patient isolation or cognition, caregiver support, those kinds of things? And then are you also facilitating any type of referrals to community or other resources that can help play a role in their care?
Now, that's a loaded question. I want to try to hit all the points because it's a good question, Christina. So when you say isolation, and again, when we talk about the decreased function of these patients, you're describing exactly what they will as well. Because as again, they're withdrawing generally at the time that they begin not feeling so well as a result of the disease. And their withdrawal is not because they want to, or it's not simply because of, poor, appetite or this drastic weight loss alone. It's just because they're not able to function as they should. They have these symptoms that they cannot easily describe to other people as to why their condition is changing so drastically. This condition can do that. I mean, within a matter of, again, what we see mostly within 3 months, they will become unrecognizable, even to themselves. That gut congestion caused by that additional fluid pushing down on the diaphragm and causing them to not feel even well enough to eat, again, can cause them to be weak and fatigued all the time to where they just don't go out. So when you talk about not feeling well enough, to get up and fix food. So now we're talking about a food access issue because they're not able to shop for themselves, they're not able to cook for themselves. And those who are not able to get, say, for instance, meal delivery services or have in-home family or relatives, even neighbors to cook for them or bring them food, that can cause the type of isolation that you're referring to. Do we refer out to services? Sure we do. We do work alongside with our medical social workers, and they will help us connect those patients to resources that can help them get what they need. The other thing that I do quite often is that I will also tie them in to the companies that provide the oral nutrition, the supplements. We will go ahead and apply for that assistance for them. So it is at no or low cost to them to have those supplements delivered, or we will provide them at a discounted rate to make them more affordable because the medications for this population are quite costly. So anything that we can do to assist in food access, food delivery, to make sure the nourishment gets in, because again, as you know, nutrition is nothing if it does not get, one, delivered properly, if it's not absorbed, if it's not taken in on a consistent basis. So we do all we can with those wraparound services to assist our patients in sustaining their weight and preventing them from losing additional, lean body mass or, again, weight that's out of their control.
So aside from the disease process, are there any elements of the patient's treatment that actually puts them at a nutrition disadvantage? I'm thinking like with renal patients, some of their nutrients are dialyzed out, or, with like paracentesis, they're pulling out protein, right? So is there anything in this patient population that we should be aware of that may be putting them in a nutrition risk?
Well, sure, because, 2/3 of this population, okay, has the sequelae that I described, that they have this malnourishment. And so certainly that can preclude delayed wound healing. It can increase their infection risk, their readmission rate over time that this is occurring. So it can definitely put them at risk for some other outcomes that are indirectly related certainly to their condition. But I can't underscore enough how that functional decline, it's like almost just an accelerated breakdown overall. And we do see, cardiac cachexia in these patients, which ultimately is associated with adverse outcomes as well. So does it put them at risk? Of course, that protein calorie malnutrition, again, can cause them to again, not just a physiological weakness, but just not to be able to take in adequate nourishment. And over time, like I said, it can lead to uh, uh, the cachexia, the greater admission rate, just overall, again, an accelerated breakdown of functionality. And I think, that's the best way that I can describe that to answer your question, Christine.
And then when it comes back to to their fluid, how are you balancing oral fluid restrictions with adequate calorie and protein, especially when you're looking at using oral nutritional supplements?
Well, right. And they do have supplements. That's a great question as well. They do have supplements that are formulated specifically for fluid restricted patients. So obviously they're calorically dense with less volume. Now, the taste for a lot of patients is the challenge, if you will, because they're not necessarily used to doing those. But thankfully, a lot of these companies that provide these products now provide them with, kind of recipes on how to build around the supplements, whether they be smoothies or kind of homemade protein drinks. They can do them chilled, different things like that that will make them a little more palatable and acceptable. Because again, if we're providing nutrition that the patient is not, it's not appealing or that they do not want to take in, then we're not going to make any reasonable gains to get where we want to be in the prehabilitation part, because a lot of what we do in early nutrition intervention preoperatively is that, we're looking to optimize these patients. We're looking to improve their nutritional status so that they may have good strength, healing, and recovery on the post-op side.
So when you're monitoring your patients and you're thinking about their body composition, what tools or approaches have you found to be the most practical and clinically meaningful at the bedside?
Monitoring body composition or assessing body composition?
Well, either way. So like your initial assessment, or if you're monitoring a patient like pre-op versus post-op and you're seeing these fluid changes, how are you accurately assessing their composition? Or are you able to? Like, are we able to get an accurate reading?
So, we try to use those bedside tools, much like, say, for instance, the nutrition focused physical exam. So, which assesses temporal wasting, clavicle prominence, quadriceps loss, grip strength. We can use those indicators to see. The other thing, well, some of the tools that we would use, obviously, in the outpatient setting, we don't generally use in our particular practice, where we're talking about um, the skin fold caliper, but we can, use calf circumference. Obviously, we can measure that to see if there's been any significant amount of muscle mass loss. But a lot of that too, I will say we work very closely, thankfully, with our physical therapy staff. Our team saw early how important it was for nutrition and physical therapy to work very closely together, because without good nutrition, patients' movement certainly or will essentially become less and less. And so we want both of those things to work in tandem. So physical therapy has the, six levels that they measure that give them a frailty score. And then, of course, we have the nutrition screening. And together we come together to see how we can work to make sure that they are maintaining that lean mass. We are very aggressive about that, even to the extent of, if we do have a patient whose gut is functioning, but they need a little help to encourage them while they're getting tuned up, we may start supplemental tube feeds at night and allow them to eat ad lib during the day, right? Because the point is to uh, stop, or to mitigate the loss of lean mass as soon as they get to us, in whatever means necessary. So if we know that we've got to give them some supplemental to get them to, again, to sustain their current weight and avoid any further loss of unintentional body weight, then that is what we do. And as they start to feel a little better and they're able to eat more and more on their own, of course, then we'll relieve the supplemental nutrition and allow them to get 100% of their nourishment orally. But we'll do whatever it takes because, again, our job is to make sure that we're optimizing them and minimizing, the adverse effects from malnutrition.
And thinking about micronutrient deficiencies, which are oftentimes overlooked, I think, in the hospital setting, which deficiencies are you most concerned about? And then what's your approach to supplementation in these patients?
Micronutrient deficiencies, we see quite a bit of iron deficiency in patients, um, which generally we can attack with, again, the supplementation, because the medical staff is going to give the patients, something to go along with. One of the things that is fairly common in this population is what has been described as cardiorenal syndrome. So there's a bit of kidney dysfunction, if you will, acute kidney dysfunction that can also occur with these patients. And so we certainly have to walk a tight rope, if you will, with the amount of protein provision, knowing that it's really not a frank renal disease, but it's more due to their heart failure. But we still walk a tightrope there. So, but in that, we again will see quite a bit of um, iron deficiency. I think that's probably the most prevalent one. We generally don't see like potassium or phosphorus, perhaps calcium, which sometimes may be elevated due to immobility, more so than the calcium deficiency, but we do watch that quite often. Our patients will get a calcium vitamin D supplement, certainly more so in the outpatient setting, but in inpatient, we're monitoring those regularly to correct as we need to.
Well, we've just got a couple minutes left. So I know you've got a ton of experience working with multidisciplinary teams. So
Yes.
when you're doing this, how do you advocate for nutrition really as a priority intervention, especially when there's so many competing medical issues that are taking center stage?
So here's a question I am excited to answer here, Christine, because I have been fortunate to work with a team of medical staff that put nutrition in the forefront. It didn't start out that way. It was something, as you said, that we had to make a case for. And because early on in my career, I worked in advocacy. So we lobbied for things like getting the nutrition covered by insurance. So one of our CPQI, our quality improvement measures, say for instance, is making sure that we do what we call an RD query. When we see that a patient meets the criteria for moderate or severe protein calorie malnutrition. And when we do that, then the physician actually has to sign off for that to be added to the patient's overall diagnosis for that visit. And then, of course, the dietitians or the hospital health system gets reimbursed for that diagnosis as well. So that adds value. That's one way, obviously, in the numbers, because, these are systems, these are businesses, they deal with numbers. But the second part to that is being required to be a part of this team by the Center of Medicare and Medicaid Services. Dietitians are required to be a part of this team to do their initial referrals and to follow them through outpatient as well, inpatient and outpatient throughout their care. That's the second thing. They know we're there. We make sure that we're accessible at every point of care. That's extremely important. We make sure we're there to work alongside the physicians, to provide counsel, give advice, change orders, give education, whatever we need to do. I've done quite a few in-services for not only the physicians, but the ICU staff. I'll come early, I'll stay late, whatever we need to do to make sure they understand how critical it is to pay attention to nutrition in the daily rounds. And they already have it now where every day we round on our patients in the morning and in the afternoon, but the morning round specifically, because obviously that sets the tone for the day. And nutrition is already baked in to one of the topics that they will present on. And again, we're there. So when we need to chime in, we chime in. If they need to ask a question, we're there to answer. So this is all a part of the total care that our facility offers. So I am quite fortunate to have a team of medical providers that already knows how important nutrition is. They welcome it, they invite it in. And to the extent I'd like to go ahead and also give a nod to our program, because we just published a second paper and were accepted to present that publication at the recent 2026 ISHLT conference in Toronto. So they also back the research that we do and are proud of the work that we accomplish, not just as dietitians, but as a team. So we very much feel we very much feel like dietitians are a valuable part of this team, and we're supported as such.
Well, that's wonderful. Well, congratulations on your recent submission, and really for all you're doing. I think the work you're doing elevates all of us. So thank you so much.
Thank you, Christina. Thank you.
And listeners, I hope you enjoyed today's episode. We would invite you to check out our website at dnsdpg.org. We have a ton of nutrition-related resources available, many of which are at no cost to our members. So be sure you check that out. Until next time, I'm Christina Rollins. Thanks so much for listening.